Hello and welcome to Time and Range's third webinar, Novel Biochemical Markers of Glycemia to Predict Pregnancy Outcomes in Women with Type 1 Diabetes. My name is Dr. Denice Feig and I will be moderating today's webinar. To share a little bit about myself, I am Professor of Medicine in the Division of Endocrinology at the University of Toronto in Canada and Senior Clinician Scientist at the Lunenfeld-Tannenbaum Research Institute. I'm also head of the Diabetes and Pregnancy Program at Mount Sinai Hospital in Toronto. My research focus is in the area of clinical trials, epidemiology, and use of technology in women with diabetes and pregnancy. None of this would be possible without the guidance of the ADA's Time and Range Advisory Group. We would like to thank the members for all their hard work to develop today's webinar. Let's see who we have joining us in today's program. Please let us know where you are joining us from. If you want to type in the chat box the organization and state you are joining from. Let's see. Well, we'll see who's joining in a moment. To become a member of the American Diabetes Association, ADA membership will provide opportunities to network and grow professionally. ADA memberships include a variety of professional member benefits, including meeting discounts, Women's Interprofessional Network, interest groups, Diabetes Pro Member Forum, professional journals, members-only webinars, member directory, standards of medical care in diabetes, and Diabetes Pro Quarterly. ADA memberships include a variety of resources. So become an ADA professional member. Visit professional.diabetes.org/membership for more information. And I can see there's people from McGill University, Mercy Health, Illinois, Seattle. Great, thank you so much for joining us. Another great resource of the ADA is the ADA Primary Care Certificate Bundle. It is designed to help clinicians on the front lines of primary care master the latest ADA standards of medical care in diabetes and confidently apply strategies for overcoming therapeutic inertia. It includes the popular Diabetes is Primary and Overcoming Therapeutic Inertia certificate programs and provides up to 22 CE credits. You can also register for either the DIP or the OTI program separately and build your own educational experience by choosing individual modules to register for. To learn more and register, visit the online programs page using the link on the slide and in the chat. Time and Range wants to hear from you. Join ADA's newest online collaborative, Time and Range Online Collaborative, to join the discussion. By becoming a member, you would share best practices, request input on challenges, share interesting articles, expand your network, and browse Time and Range content. For more information, visit professional.diabetes.org/time and range. The Time and Range initiative provides resources for clinicians to increase their knowledge on time and range to enhance uptake with their clinical practice. The goals of this program are to increase knowledge of time and range, understand how HbA1c, CGM metrics, and alternative biochemical markers of glycemia are predictive pregnancy indicators, and recognize the benefits of tracking time and range during pregnancy. We'll spend today's program by following the agenda on the screen. Please note that today's presentations will be followed by a Q&A session. If you have questions as we move through the presentations, please type them into the Q&A box in your control panel. We'll be answering as many questions as we can at the end of both presentations. Now I'm excited to introduce to you today's speaker. She brings a unique perspective to our discussion. Dr. Claire Meek is a clinical consultant in diabetes and pregnancy at Addenbrooke's Hospital in Cambridge, UK, and a principal investigator at the Institute of Metabolic Science, University of Cambridge. She's supported by a Diabetes UK Intermediate Clinical Fellowship and Future Leaders Award from the European Foundation for the Study of Diabetes in association with the Novo Nordisk Foundation. Dr. Meek's research interests include diabetes, nutrition, and obesity in pregnancy. We're excited to have Dr. Meek with us today. So let's get started. Thank you, Dr. Meek.
Thank you very much, Denice, for that introduction. It's a real pleasure to be here today and also to see people here from around the world as well as all around the United States. So thank you very much for inviting me to speak. We're going to talk today, myself and also Professor Corcoy, about a project we've done recently, novel biochemical markers of glycemia, predicting pregnancy outcomes in women with type 1 diabetes. And this was a part of the CONCEPT randomized control trial. And CONCEPT itself was sponsored by the JDRF, but the current analysis was also very much supported by the EFSD. So thank you very much to our funders and also to Diabetes UK who fund me personally. So we know, all of us who are involved in day-to-day pregnancy care, that assessing glycemic control in pregnancy is vital. And yet, of course, there are many challenges. We know that HbA1c is known to have limitations, although it's obviously still very widely used. And our hope was, coming out of the CONCEPT study, that continuous glucose monitoring may offer new opportunities for us to predict pregnancies at high risk of adverse outcomes, that we might be able to intervene meaningfully at an early stage. And so the aim of the current study was to compare the ability of biochemical markers and continuous glucose monitoring metrics to predict outcomes in pregnancies affected by type 1 diabetes. And I'm going to concentrate today on 4 major outcomes of interest: preterm birth, large for gestational age, which was centile over 90% based on customized centiles or Gros criteria. Neonatal hypoglycemia, defined as, according to 3.5 millivolts per litre. I'm just trying to remember, I think that's 63 milligrams per deciliter. And also neonatal intensive care unit admission, which was for at least 24 hours. We're going to talk through, first of all, if this is a sort of a race, if you like, to find the best marker to predict outcomes in type 1 diabetes pregnancy, then who are the contenders for this? And so if we look at the contenders, first of all, looking at HbA1c, HbA1c is, of course, the standard of care. It reflects glycemia over around about 2 to 3 months, but it is very much affected by iron deficiency anemia, gestational age, ethnicity. Of course, there are some ethnic groups who have particular hemoglobin variants that impact upon the reliability of HbA1c. And so there has been concern over many years that actually HbA1c may not be that reliable in pregnancy. There have, however, been a number of new biochemical markers available, and one is called 1,5-anhydroglucitol. Now, this is thought to be a naturally occurring monosaccharide, reflecting glycemia over around 2 weeks. And this monosaccharide competes with glucose uptake in the tubule of the kidney. And so whenever glycemia is high, 1,5-anhydroglucitol levels are low. We also have had a range of new developments really within the glycated protein space. Fructosamine is a very old marker, total glycated serum proteins, but over the last number of years, glycated albumin, a more specific marker, has been available as well. And these are thought to reflect glycemia over 2 weeks. Now, there's some benefits, at least theoretically, to using glycated proteins rather than glycated hemoglobin, and they're less likely to be influenced, for example, by iron deficiency anemia and so forth. And then the 4th biochemical marker that we're going to look at is called GCD59, and this is a glycated complement protein 59. And the complement protein itself prevents cell lysis following activation of complement, and glycation of that protein slows its action. And this is thought to reflect glycemia over around 2 weeks. So then thinking through the CGM metrics for this study, so you can see that we used many of the standard metrics that you'll be very familiar with: mean CGM glucose, time in range, time above range, time below range, coefficient variation, and standard deviation of blood glucose. We use the standard pregnancy range as recommended, 63 to 140 milligrams per deciliter. So if we think about this as a race, then which marker is the winner? So I'm going to start off by showing a range of graphs like this, really taking each marker in turn. And these graphs show the standardized odds ratio. So that's the odds ratio for one standard deviation increase in the marker here, 1,5-anhydroglycitol. And you can see I have shown data here from 12 weeks, 24 weeks, and 34 weeks for each of those 4 outcomes we discussed earlier. So preterm birth, large for gestational age, neonatal hypoglycemia, and NICU admission or admission to the neonatal intensive care unit. And you can see here that 1,5-anhydroglycitol shows a number of significant findings. But nothing very significant, but there are a few things picked up really from 12 weeks. But if we compare this to other markers, do we find any benefit? Well, first of all, fructosamine, a very old marker, and certainly there are some borderline significant changes here you can see with very wide confidence intervals. Those are the error bars there showing 95% confidence intervals. So fructosamine overall, perhaps a little disappointing. Can we improve upon that with glycated albumin, the new kid on the block? Well, the short answer is no. Unfortunately, glycated albumin didn't really improve the predictive ability here, and in fact was really quite sporadic in terms of predicting those important outcomes. So what about moving on then to our other measures, GCD59 and HbA1c? And here's where the story changes, I think, a bit. So both GCD59 and HbA1c are able to identify multiple outcomes and across those 3 time periods. So taking GCD59 first, you can see that actually it really stars at 24 weeks, where it's a really strong predictor of neonatal hypoglycemia and also NICU admission. And you can see that actually compared to all the other biochemical markers, it was the strongest single indicator of neonatal hypoglycemia and NICU admission in this study at 24 weeks. However, HbA1c is really also able to give a very good performance here, both at 24 weeks and at 34 weeks, able to identify numerous outcomes of interest. And I think in some ways that's surprising, but also very encouraging to support the clinical care really around the world that relies on HbA1c. So moving on then to CGM metrics, can we discuss which one would be best? Well, here is the mean CGM glucose, again, same sort of graph really, and you can see that the mean glucose performs pretty well at 24 weeks and a bit really at 34 weeks, but time above range does perhaps a slightly better job at 34 weeks, so able to identify multiple outcomes of interest, both at 24 and 34 weeks. And what about time in range then? How does that compare? Well, you can see that actually of these 3 metrics, the time in range actually performs excellently at 12 weeks. So able to identify, even in early pregnancy, 4 outcomes of interest. And you can see that actually all the way through, it's just a really solid predictor of multiple outcomes. So can we improve upon this with anything else? Well, no, time below range had no significant associations, and actually coefficient variation, no significant associations. And standard deviation of blood glucose is very much related to the mean blood glucose, but once you adjust for that, it has no significant independent associations here with variability alone once you take the concentration into account. So where does that then leave us? Who then is the winner, if you like? So would we choose CGM or would we choose HbA1c if we had only one choice to make? And I think really here you can see them side by side. Time in range, the best CGM marker, and HbA1c, certainly one of the best biochemical markers. And I think it's clear that time in range is more predictive at 12 weeks, but actually HbA1c is probably more predictive at 34 weeks. And so when we use these together, I think this is very encouraging that we can good pregnancy risk assessment really all the way through. So in the clinic, what would happen if we had no HbA1c? Well, you can see that actually the time in range and the time above range together also provide very good coverage. So the time in range better at 12 weeks, the time above range better at 34 weeks, but overall very consistent. And then what about if we have no CGM, as of course happens in many places internationally still in type 1 diabetes? Well, we can see that actually HbA1c is providing excellent predictive ability at 24 and 34 weeks, really encouraging ability to pick up multiple markers of interest, multiple outcomes of interest. So then thinking through our conclusions, I think we can conclude that time in range and HbA1c both offer very good predictive ability for multiple outcomes of interest. And the best CGM predictors were time in range, time above range, and mean CGM glucose. Probably the best single one was time in range. Time in range can predict preterm birth, large for gestational age, neonatal hypoglycemia, and NICU admission from 12 weeks. But HbA1c also performed very strongly at 24 and 34 weeks. And we also had the novel marker GCD59, was a very strong neonatal outcome marker when measured at 24 weeks. So I'd just like to say a big thank you to the women with type 1 diabetes who took part in the concept trial, also our concept collaborators, including Denice and Rosa here with us today, and the rest of the study team. Thank you very much. This paper was published recently. I'd just like to draw your attention to it in Diabetes Care, and I'd like to thank my other co-authors who aren't here today. And please do get in touch with us if you have any questions. Thank you very much.
Thank you so much, Dr. Meek. I'd like to encourage all the attendees to input their questions into the Q&A box to discuss at the conclusion of both presentations. I now have the privilege of introducing Dr. Rosa Corcoy, who will be providing additional insight to time in range and HbA1c targets in pregnant women with type 1 diabetes. Dr. Rosa Corcoy is the director of the Diabetes Unit at Hospital de la Santa Cruz y Sant Pau and associate professor of medicine at the Universitat Autònoma de Barcelona. Dr. Corcoy's main areas of interest are endocrinological conditions in pregnancy, type 1 diabetes, and technology and diabetes. She is author and co-author of 180 publications in peer-reviewed journals. She has received the 2012 Jorgen Pedersen Medal of the EASD Diabetes Pregnancy Study Group. We are excited to have Dr. Corcoy with us today. So let's get started. Dr. Corcoy.
Thank you very much, Denice, for the introduction. I want to join Professor Feig and Claire Meek in expressing my gratitude to the organizers of the Time in Range ADA initiative for this invitation for this webinar. The title of my presentation is CGM Time in Range and Hemoglobin A1c Targets in Pregnant Women with Type 1 Diabetes. So for the second part, we move from the first part where Dr. Meek analyzed the predictive ability of different glucose biomarkers for pregnancy outcomes, and where these glucose biomarkers were expressed as continuous variables. For the current exercise, we will just focus on two of these biomarkers, time in range and hemoglobin A1c, and express them not as continuous variables, but as we usually do in clinical practice, as those women fulfilling a specific predefined goal. As for CGM targets, we have these specific pregnancy targets defined in recommendations of the International Consensus Timing Range in 2019. And the aim is a target range between 3.5 and 7.8 millimole per liter. And the specific aims for time below range would be less than 4% of the time, for time in range more than 70% of the time, and for time above range less than 20%, 25% of the time. As to hemoglobin A1C targets, according to NICE 2020, the guideline for diabetes in pregnancy published this year, both for preconception, first trimester, and throughout pregnancy, the goal would be an hemoglobin A1C lower than 6.5. As to ADA standards of care in 2022 and also in years before, the target would be less than 6.5 in preconception and first trimester, and less than 6.0 in the second and third. Thus, for this ancillary study, the aims were first to examine the CGM-based and ADA hemoglobin A1C target glucose attainment in pregnant women participating in the concept trial. And second, to evaluate the associations between CGM and hemoglobin A1C target attainment with pregnancy outcomes. First, target attainment. Here we have the outcome variables for this analysis, and these are the percentage of women who reach CGM-based target attainment in each trimester, and the percentage of women who met the ADA hemoglobin A1C targets in each trimester, according for both of them to those cutoff that I have mentioned before. This is the study population. In the slide, we can see the flow diagram for participants' inclusion. Some women came from the pregnancy trial, some from the planning pregnancy trial who became pregnant during the study. The potential study population was 249 women. And for those women, we had data for CGM and hemoglobin A1C for both of them. In the first trimester for 221 women, at 24-25 weeks for 197, and at 34-35 for 172. I have to mention here that CGM data corresponds to an information of 6 days, that in women in the CGM arm, we are coming from the real-time CGM, and for women in the control arm from retrospective CGM. Here we have the baseline characteristics. In the study population, the age was 31 years. Most women were from European origin and had post-secondary education. The BMI was just over the cutoff for overweight. The duration of diabetes was about 17 years, and about half of the women were using an insulin pump. Overall, the characteristics of the study population were very close to those of the potential study group of 249 women. Here we have the average, the summary of the hemoglobin A1C and times in a range throughout pregnancy. The hemoglobin A1C went from 6.8 in the first trimester to 6.3 in the second, and again 6.3 in the third. And we can see that the times in range, 8.3 for time below range the first trimester, 51% time in range in the first trimester again, and 40% time above range in the first trimester. In the second trimester, there were not much changes, but in the third trimester, the times in range were improved. In this slide, we move to those figures for CGM expressed in terms of target achievement. We have the results expressed in absolute numbers of women attaining the targets. In red for women attaining the time below range, in green for women attaining the time in range, and in yellow for women attaining the time above range. And the number in the white square is for those women not attaining any of those ranges. We can see that in the first trimester, the highest number is for women not achieving any of those targets, while in the second and in the third trimester, the highest number is for women attaining the time below range. In this slide, we have the same information as in the one before, but we have added the percentages of achievement of times in range. And in summary, we can see how the best numbers are in the third trimester. About a little more than the half of the women were achieving the goal for time below range, and a little more than a third were achieving the targets for time in range and time above range. I have not mentioned, but in all these slides, the two groups, the two arms of monitoring treatment, both CGM and control groups, are combined. In this slide, what is added is in black squares, is the percentages of women not achieving any of the targets. In the first trimester is about 54%, and this decreases towards the third trimester where it is 6%. And finally, these are the rates of achievement of time of the three targets. The figure is 2.7% in the first trimester, even slightly less in the second, and 17% in the third. And now we move to hemoglobin A1C target achievement. The figures in the first, second, and the third trimester is 20-something. They don't change much. The significance of change across the trimesters is not significant. And this finding may be surprising is because that despite hemoglobin A1C concentration decreased during pregnancy, the target was also more strict in the second and third trimesters, so that the percentage of women achieving the target did not move much. And in this slide, we have again the rates of women attaining the three targets, the target above range, in range, and below range in the three pregnancy periods, the three trimesters, but now they are split according to they belonging to the control or the CGM monitoring arms. We can see that throughout pregnancy, for the three targets and for all the groups, the control and the CGM groups, the percentage of women attaining the targets increased throughout pregnancy. But if we now look at the columns and the comparison between women in the control and CGM arms, in the first trimester and in the second trimester, all the groups, the differences between the groups were non-significant, and they just became significant for the three comparisons at 34 weeks, where the number of women, the percentage of women attaining the targets were higher in real-time CGM groups for the three targets, for time above range, for time in range, and for time below range. Now the same exercise for hemoglobin A1C. And we have to look at the non-dashed cells that correspond to the ADA hemoglobin A1C targets. Again, no differences between the groups in first and second trimesters, and again, a significant difference in the third trimester, where the rate of attainment of the hemoglobin A1C target was higher in the real-time CGM group, 31% versus 17%. Now the association with outcomes. The study population is slightly different than for the previous analysis. The numbers are somewhat smaller, and this is because the study population is limited to those women with pregnancy progressing to 20 weeks or more and with information on the outcomes. This makes a number of 204 in the first trimester, 196 in the second, and 171 in the third. These are the CGM targets and ADA hemoglobin A1C targets that were the outcome variables for the previous analysis. And for the current analysis, these become the exposure variables. For this analysis, the outcomes are pregnancy outcomes, 2 of them maternal, preeclampsia and cesarean section, and 4 of them corresponding to the newborn, preterm birth, LGA, neonatal hypoglycemia, and NICU admission. And in this slide, you can see the rates, and they are very similar to those reported in the main concept publication. In this slide, what is summarized is the bivariate association between these exposure variables implying the exposure to maternal glucose and the 6 pregnancy outcomes. The bars indicate the odds ratio, the red ones for time below range, the green ones for time in range, the yellow ones for time above range, and the violet ones for hemoglobin A1C. The horizontal line indicates an odds ratio of 1. And we have indicated the numbers just for those variables that had a significant association. There were 14 of them. Most of them are for hemoglobin A1C in violet. And we can see that the odds ratio is below 1, meaning that the direction is towards a decreased risk with meeting the goal of hemoglobin A1C. There are also some significant associations in green and in yellow for time in range and time above range, also in the direction of lower risk when meeting the target. But we also have 2 red associations for time below range and for neonatal hypoglycemia and for NICU admission. And these are in the direction towards a higher risk when meeting the goal. Now we move to the same analysis, but in a multivariate analysis where it is adjusted for 9 additional variables, including characteristics such as maternal BMI or diabetes duration. Now the number of significant associations are reduced to 6, 4 of them for hemoglobin A1C, in the direction of a protection of a decreased risk for preterm birth, for LGA, and for neonatal hypoglycemia, and 2 of them for time below range. And intriguingly, the association is towards a higher risk, a higher rate of preeclampsia when meeting the goal for time below range in the first trimester, and for neonatal hypoglycemia when meeting the goal for time below range at 24 weeks. Thus, the conclusions of this analysis would be, first, that concept trial participants had a low rate of CGM and hemoglobin A1C target attainment, especially for the trimester-specific ADA hemoglobin A1C targets, which were unchanged during pregnancy. Second, that attainment of CGM and NICE hemoglobin A1C targets increased throughout gestation, and all targets were more likely to be achieved by real-time CGM users at 34 weeks. And third, that ADA hemoglobin A1C target achievement was independently associated with better perinatal outcomes, whereas the independent association of time below range target achievement with increased risk warrants further study. Here is the front page of the corresponding paper published last year in Diabetes Technology and Therapeutics. And last but not least, the acknowledgements, first to the participants in the concept trial, second to concept researchers and co-authors, with a special mention to Dr. Diana Tundidor, that is the first author of this paper, and third to the funders, the Juvenile Diabetes Research Foundation and the European Foundation for the Study of Diabetes. And that's all. Many thanks for your attention.
Thank you so much, Dr. Corcoy. Those were great presentations provided by both of our speakers. We'll now be transitioning to the Q&A portion of our program. If you have not already done so, please submit your questions in the Q&A box. So our first question from the Q&A box is from Belinda Moore. What about women using Libre? Does time and range apply to those using Libre as well as Dexcom Medtronic? As we know, Libre is often inaccurate. And I think a related question is, could both speakers please clarify what CGMs were used? Dexcom versus Medtronic versus Libre. I'm interested if there was any significant differences in outcomes depending on choice of device. Great question. Who would like to answer that? Dr. Meek, would you like to start?
I will start us off, that's fine. Thank you very much, Belinda, lovely to hear from you. So we used in the concept study Medtronic devices. Obviously, that trial started quite a number of years ago, quite many years ago, in fact, and so CGM equipment has obviously changed a lot since then. At the moment, we have no very good data comparing different CGM equipment in pregnancy. The study that we've talked through is really one of the only ones with the scale of outcome data available as yet, although I'm sure there will be more to come. So in a sense, we can't give any definitive answers about this. As Libre becomes a bit more widely used in type 1 diabetes in pregnancy, I expect we'll see a bit more to that. From my point of view, I think one of the issues with Libre is the tendency to read a little bit differently overnight, and particularly to sometimes underread. And I think there have been plans in future generations, if you like, of Libre to address that. However, from an analytical point of view, it's always going to be very difficult for the CGM devices to perform excellently at such a low concentration. And I think, as time goes on, I'm sure that ability will improve in Libre, but also in other equipment as well. I don't know if Rosa would have anything to add there, or Denice.
Rosa?
Yeah, yes, I think that's really a great question. And in practical terms, we can only use the same times in range for all the CGMs. But maybe qualitatively, we can do some appreciation. This paper that was published several months ago from the group from Copenhagen, where the Libre, especially in the night, as Claire has mentioned, had a higher rate of low values. I think we can qualitatively accept, let's say, different times in range for women using Libre and having a good number, high rates of low values at night. But that I think at the moment, this can just be a qualitative appreciation. We cannot use different cutoffs or different percentages for women using different sensors.
Right. And I think, but we all obviously have to make sure that they're not having hypoglycemia unawareness and not feeling the lows, right? That they're not true lows. And the Swedish study, if you recall, where they were comparing real-time CGM to Freestyle Libre in an observational cohort study, found increased time below range. And so we don't really know if it's because they don't have the alarms. So I think once the Libre, everyone's using with alarms, I think we'll also be able to feel more confident that those who are not using alarms were not missing hypoglycemia because they had more time below range without the alarms. Okay. Could both speakers please, oh, that was it. From Sarah Mart, question from the chat window. On the traditional clarity reports for Dexcom G6, you can set time and range in 5 milligram increments only. Do you suggest setting 60 to 140 or 65 to 140 to look at our time and range?
So I would say that would be a question we would need to take up actually with Dexcom. And it seems to me that actually as the pregnancy community, perhaps we should be doing that. I think if we have a national or an international approach or a consensus statement suggesting it should be 63 to 140, then, you know, perhaps we should be saying, can you change clarity to allow us to do that? I'm very happy to approach Dexcom to do that, but perhaps if we all did, it might carry even more weight.
Thank you. Would you have the same goals for time and range and target range for women with pre-existing type 2 during pregnancy? Rosa?
Well, I think we know that the consensus was not so specific for women with GDM and for and type 2. I think the targets should be for the moment the same ones, but we clearly can aim to higher range of achievement. The targets are the same, but I think it's easier and it should be doable in most cases to have not just 70% time in range, but with not so much difficulty, we could achieve 80% to 85%, probably. That's just not, we don't have numbers to support this, but we know that those women has less labial diabetes. Mm-hmm. So at least we should have the same targets, but right. probably better scores.
Right. Yes, thank you so much.
I think it's also fair to say that women with type 2 diabetes are an extremely broad range of people in terms of the duration of their diabetes. There'll be people who've literally only just developed type 2 diabetes, whereas there'll be other people who've had it for many years. And that, I think, causes quite different baseline glycemia when you're entering pregnancy. We do see that, of course, with women with type 1 diabetes, but most of them have a higher degree often of education and awareness on entering pregnancy, which isn't always the case for many women with type 2 diabetes who may have just been recently diagnosed. So I think all of that needs taken into account as well when thinking about individual patients.
Right.
I would like to add something that's subjective appreciation, but I think that if it can be safely achieved, we should really aim for higher higher percentage of time in range in women with type 2, and not be comfortable with just 71%, let's say, because we know those women have higher risks during pregnancy, not less labial diabetes, but higher risk, according to whatever it is, inflammation, obesity, or whatever. So let's say that if we can safely improve the glucose control as much as we can do this part. So if there are no special problems of hypoglycemia or whatever, this can happen in women with type 2. But if this is not the case, we should aim to really improve as much as we can to help them to have as good as possible glycemic control during pregnancy.
Yeah, excellent points from both presenters. Thank you so much. From Rana Al Musa, why is the second trimester in concept trial starting from 24 weeks as per table share by Professor Rosa? Rosa?
Is not a beginning there, is the point where we had the measurement. Right. So I refer to it as second trimester is just a couple of weeks representing the second trimester. And yes. The same for the third.
Right. It just so happens those were the weeks that we chose to represent. That's right. David Sachs. Do you envision any role for CGM for management of gestational diabetes? Claire?
Well, so this is a very interesting and topical question for us here in the UK. We have had access to CGM for women with type 1 diabetes for some time, and that's increasing, I think, in its scope. But more recently, we've also had the opportunity to apply for funding to use CGM in women with gestational diabetes who are on a basal bolus regime, so who are taking insulin regularly. So from that point of view, we're very much learning about this, I would say, on our feet in some ways. I think there are huge challenges to using CGM in GDM. I think much like the type 2 diabetes situation, many women are testing for the very first time. They're thinking about food choices for the very first time. It can be in some ways an overload of information to suddenly introduce CGM into that mix as well. And I have other concerns also that you may end up, as we've alluded to before, having low levels overnight, which can to some extent be normal in pregnancy, but which might change your treatment. So you might actually be tempted to reduce your insulin because you're aware of those low values overnight. And you could argue, we don't have clear evidence that that's in patients' best interests. So I think there's still a lot of work to be done, establishing, first of all, how we can best use CGM in GDM, and secondly, the targets that we might be aiming for, probably higher still than we could get in type 2 diabetes, but also I think how this is if it's going to be beneficial actually for mums and babies in this scenario. I mean, obviously all three of us here are very positive about CGM use in pregnancy, and I'm hopeful that we will be able to find that it's beneficial in GDM, but time will tell. Thank you.
Thank you, Claire. Rosa, do you have anything to add to that?
No, I think, of course, there are the pros and cons of overload of information and so on, but I would say that probably the pros would be more than the cons. But
yeah, but we're still awaiting good evidence to answer all those questions. I agree. So I have another question for Claire. Were you surprised about the predictive capabilities of HbA1c in the study, given its many flaws in pregnancy?
Yes, thank you very much, Denice. So my background is actually as a clinical chemist, in addition to being a physician. And so we have been told for many years that HbA1c is not very reliable in pregnancy. There's many limitations. The red cell turnover is so different and so forth. So I was really surprised actually to see how well HbA1c performs. And I think it's hugely helpful actually, because of course we've been using it for many years and it's available in every hospital really, almost internationally. So I would take great comfort actually from the fact that HbA1c does work really well actually. And I think you can think a little bit about why does it work so well? And I think one of the things that we might have been considering a weakness could actually be a strength. So the fact that you get really up to about 12 weeks representation in your HbA1c makes it actually in some ways potentially quite a good summary measure of your glycemia over a period of time. And of course, we know in pregnancy, that's relevant, isn't it? It's not just 1 week, it's not just 2 weeks, it's the sort of gradual effect of hyperglycemia over many, many weeks that causes these outcomes.
And Camille Powell is asking a question. How frequently do you tend to check A1C in pregnancy in patients using CGM? Rosa?
That's a good point. My usual practice is to measure it probably every month. Probably not needed, I agree, but it's what we are doing now. I don't know what other people are doing. Maybe this is continues to be a consequence of of earlier times without CGM, where we had all these glucose measurements, but you were never sure of the performance of the meter or the times where you were not measuring. And and having hemoglobin A1C was very reassuring to have it. I am doing every month, but probably we could do without it.
Yeah, so
That's
given
really-
that you have time in range and time above range, do you even need A1C?
Well, you could argue that for prediction, I don't know, for prediction, that's great.
Yeah,
But and the main point for having time in range and time above range is not just prediction, but improvement of
Right.
outcome. So I am not so unhappy that the prediction of time in range and time above range was not better, but their real value is to improve outcomes. And the other point here may be a weakness of our studies that we have just measured the CGM. The CGM values in 1 week, because it was the period where we had these values for the control group. And maybe I would say that probably the potential of the time in range is better than what we have seen here. At least it is like this, but maybe it's even higher.
right. If we had longer CGM than just 6 days, right? Of course. And I have another question for you, Rosa. What is your interpretation of the association between time below range and achievement with pregnancy outcomes? It was surprising, wasn't it?
Yeah, that's intriguing. It was already apparent there in the bivariate analysis, and it was even stronger in the multivariate ones, where the only significant associations for time in range were for the low values. So first of all, I think this has to be confirmed. But if we have to believe what it points, and I think an important point there is that the odds ratio was quite strong, so probably means something. My interpretation is that this means that low glucose values, let's say like this, are good for pregnancy outcomes. We can accept this, but if we have to translate this into clinical practice, the problem is how you or pregnant women go there without additional risk. So I think it's pointing that low values can be good. We know they are physiological in pregnancy, those low glucose values, even if the target the target values for pregnancy more or less are adapted to these low physiological values, but maybe they should be somewhat lower, or have a higher timing to be the time below range, maybe be higher than 4%.
I see.
They point to this direction, but this is not a definite proof.
Right. And we used the Medtronic, which should have been accurate under 4. We didn't use the Libre. So we can't say, oh, it's because it was inaccurate.
Yeah.
Okay, I think we have time for one more question for Claire, Dr. Meek. Measures of glucose variability had no association with pregnancy outcomes or were not independently associated. Do you think that therefore they have no role in pregnancy outcome prediction?
Well, I think that's a really interesting question, Denise. And actually, as you know, there's been lots of work outside of pregnancy showing variability is really important, longer term variability in HbA1c and so forth. So I wouldn't be surprised if actually this is not a story that we have the entire answer to here. It may be that variability is really important for other things. I think we all know from clinic that actually variability can make control harder. We know that it can make insulin dosing more difficult if there's very erratic levels. And so I think that we certainly didn't find any obvious evidence of variability contributing directly to outcomes, irrespective of the glucose concentration. But I think we may find it is relevant to control overall.
And I think the last question from Rana Al Musa: which glycemic control of a trimester matters more regarding LGA? Is it the second or the third? Rosa?
I would say both. Initially the second. I think the third also contributes. And there we can have the exception of women with had very inadequate control in the second trimester with very large overgrown fetuses, where we can have a paradoxical observation with, let's say, good control in the third trimester. But I think both of them contribute.
Right. Well, thank you to both presenters for really excellent presentations and your insights into this topic. Next slide. I just want to remind all of you that registration is now open for the ADA 82nd Scientific Session. The conference will be held in New Orleans and will be offered virtually. For more information and to register, visit professional.diabetes.org/scientific sessions. Next slide. This concludes today's program. I would like to thank each of you for joining. For additional resources and to register for Time and Range's next webinar, visit professional.diabetes.org/time and range. Upon exiting the webinar, you will be asked to complete a brief survey. Please provide us feedback on today's program. Thank you again for your time, and we look forward to connecting with you at the next Time and Range webinar. Thank you, everyone.